Good morning, everyone. I am Dr. Tapas Kumar Singh. I am Assistant Professor in Department of Anesthesiology. And today we are going to share our experience of using truncal blocks in kidney donor pain management. Renal transplant program started in our institute in 1989. By 2001, our department introduced acute pain services. In acute pain services, we used to manage the postoperative pain of the patient even while he has left the post-op ICU and reached ward till the point he was discharged. Acute pain services gave us a profound understanding of the analgesic requirements of the patients and the problems our surgical colleagues face while managing them. Laparoscopic approach to donor nephrectomy was started in our institute in 1998. By 2002, laparoscopic approach became the standard of care. Unless until there was an anatomical or a physiological contraindication, most of our patients are done most of our donor nephrectomies are done laparoscopic. Laparoscopic approach has lesser analgesic requirements, hence it makes our job easier. In the same year, in 2002, our department started patient-controlled analgesia. Now, in patient-controlled analgesia, basically, we give the power to the patient to self-administer an analgesic dose whenever he feels that his pain threshold is above his comfort level. Now, this is achieved with the help of a computerized pump. Whenever patient presses a button, that computerized pump delivers a certain dose of analgesic. What we anesthetists do, that we program that pump. So, no matter how much the patient presses according to his pain threshold, only a certain safe dose of analgesic will be administered to the patient. Patient control analgesia gives a sense of control to the patient, and in all the studies, PCA has shown better patient satisfaction score compared to time-bound analgesia regimen. In 2008, ultrasound arrived in our department. Now it changed the way how we used to approach regional anesthesia. Earlier, our nerve blocks or regional anesthesia blocks used to be dependent on gross anatomy, and they used to be essentially blind procedures. With the advent of ultrasound, what has happened now, we can see those nerve plexus or muscle plates. We can see where our needle was moving, and they became ultrasound guided. Hence, our regional anesthesia blocks became more safer and efficacious. In 2012, the era of ERAS was born. ERAS stands for Enhanced Recovery After Surgery Protocol. In ERAS protocol, there is stress on two things in post-operative period, that is early ambulation of the patient and early resumption of oral feeds. Both these two things depend on good post-operative analgesia. However, this good post-operative analgesia has to be achieved with an opioid-sparing method, because opioids have obvious side effects like nausea, vomiting. They cause increase in incidence of post-operative ileus, somnolence. All these things interfere in the recovery of the patient. Hence, ERAS stressed upon the concept of multimodal analgesia or opioid-sparing analgesia. Now, the advent of ultrasound and the efficacy of ERAS protocol brought truncal blocks into even more focus than they were ever before. What are truncal blocks? Truncal blocks are basic. We all know the thoracic and the lumbar spinal nerves, after originating from the vertebra through the intervertebral foramina, they travel in muscle planes. Now, in truncal blocks, unlike nerve plexus blocks, where we see a nerve or a nerve plexus and try to block it, in truncal blocks, we basically try to identify these muscle planes and deposit local anesthetic in those, with the hope that the nerve which is traversing through them will also get blocked. We will discuss about truncal blocks in detail later. Now, coming back to the surgery. As I have said earlier, laparoscopic approach has made our job a lot easier. However, even with laparoscopic approach, there are significant avenues for nociception. Patient might suffer from port side pain. There are actually 4 ports inserted, so it might cause considerable pain to the patient. There is a significant amount of blunt dissection and dissection, which might result in visceral pain. Laparoscopic donor nephrectomy is not actually completely laparoscopic, because there is a modified lower Fannel-Stein incision, if you see my cursor here, of approximately 5 to 6 centimeter, which causes pain. Like all laparoscopic surgeries, there might be diaphragmatic irritation due to residual carbon dioxide, which is used to create the pneumoperitoneum. In donor nephrectomies, our patient is also special. He's actually, most of the time, he's not a patient at all. He's a reasonably healthy volunteer who is donating his kidney for an altruistic purpose. Now, this guy, if he suffers from a short-term or a long-term complication, it would be really tragic. Over the years, our understanding of post-operative pain and its implications has also evolved. Now, we believe that post-operative pain might lead to something called chronic post-surgical pain. According to the International Association of Study of Pain, they have defined chronic post-surgical pain as any pain which exists for greater than 3 months after surgery when all the other causes have been excluded. According to a study published by Goins et al. In American Journal of Transplant in 2019, they reported that approximately 6% of voluntary kidney donors reported chronic post-surgical pain after lap donor nephrectomy. There are a lot of studies done to identify the risk factors for chronic post-surgical pain. However, almost all studies agree on that early post-operative pain, especially dynamic pain, is an independent risk factor. So what is so problematic about chronic post-surgical pain? The problem with chronic post-surgical pain is that it is less somatic, it is more affective in nature. Hence, it affects the behavior of the patient. If you ask these patients, they will always report a low quality of life. Since the pain is more cortical in nature, it becomes even more difficult to treat. Adding to the risk profile, few studies have identified female gender also as a risk factor. So, most of our donors in our institute are females. Majority of them are females. So, our voluntary kidney donors are at increased risk of chronic post-surgical pains. Hence, we need to manage their acute post-operative pain pretty well. The application of ERAS protocols has resulted in 30 to 50% of reduction in length of stay, better quality of recovery, and fewer complications and fewer costs. Now, post-operative analgesia is the cornerstone for ERAS. For anesthetists, two things are very important: intraoperatively and post-operatively. That is opioid-sparing anesthesia in intraoperative period and multimodal or opioid-sparing analgesia in post-operative period. We all know a patient who is pain-free will ambulate quickly and will tolerate feeds better. However, this adequate post-operative analgesia is to be achieved in an opioid-sparing method, as I have already described the side effects of opioids. The basic premise of multimodal approach or opioid-sparing approach is very simple, that we need to attack pain through various mechanisms of action. When we attack pain through various mechanisms of action, we increase the efficacy and decrease the side effect of one particular method. Hence, we get good pain control without any side effects. In our multimodal approach for donor nephrectomy, we have following options. NSAIDs, which we obviously don't use in our transplant program because of their obvious side effects like AKI. Opioids, as I have said, they are very potent analgesics. However, they are associated with side effects which delay the recovery of the patient. Epidural analgesia is our time-tested technique, and it is very effective for post-operative analgesia. However, it is technically difficult and invasive in nature. We usually don't offer epidural analgesia for patients who are undergoing laparoscopic donor nephrectomy. Then we come to truncal blocks, our topic of interest today. There are 3 truncal blocks who have evolved over years, which can be used in donor nephrectomy. One is transversus abdominis plane block, that is TAP block. Other is quadratus lumborum block, also known as QL block. And the third one is erector spinae block, also known as EL. Now, before I delve further into these blocks, let us take a quick look at the applied anatomy. As you all can see, this is a cross-sectional diagram of the abdominal wall at the level of T12 vertebra. The anterior abdominal wall, I hope everyone can see my gussets there. The anterior abdominal wall is formed by the rectus abdominis muscle. The anterolateral and posterolateral portion of the abdominal wall is formed by the 3 muscles known as, from outside to inside, external oblique, internal oblique, and transversus abdominis muscle. The posterior portion of the abdominal wall, the superficial part is formed by latissimus dorsi and the erector spinae muscle. The erector spinae muscle runs from neck to the pelvis. It runs longitudinally along the vertebral column. This muscle is the hump. If we feel in our midline, that is, if we feel our spinous processes, we will feel two humps adjacent to it. It is this erector spinae muscle. The inner part of the posterior abdominal wall is formed by the psoas major and the quadratus lumborum muscle. We can see the vertebral column here, the vertebral body here. I'm sorry. We can see the spinal nerve which arises from the intervertebral foramina. Spinal nerve, as soon as it arises from the intervertebral foramina, it divides into posterior and anterior rami. The posterior rami pierces the erector spinae muscle and supplies the skin and muscles of the back, while the anterior rami continues laterally and anteriorly between a plane between transversus abdominis muscle and the internal oblique muscle. Somewhere here near the flank, near its maximum curvature, it gives rise to lateral cutaneous branches. These lateral cutaneous branches supply the anterolateral and the posterolateral portion of the abdominal wall, both the muscles and the skin. That is what is commonly known as flank. While the anterior primary rami continues anteriorly till it reaches the margin of the rectus abdominis muscle, where it pierces the rectus abdominis muscle, gives rise to the anterior cutaneous branches. These anterior cutaneous branches supply the skin from the midline to the mid-clavicular line. Now we have seen the applied anatomy. Intuitively, we can appreciate where we can give deposit our local anesthetic in what muscle plane to block these nerves. So in 2007, the first to arrive was transversus abdominis plane block, that is TAP block. Here, like I said, the anterior primary ramus runs in a plane between the transversus abdominis muscle and the internal oblique muscle. If we deposit sufficient amount of local anesthetic in it, it will block the lateral cutaneous. Since lateral cutaneous nerves are blocked, it will result in analgesia over the flank. It usually, depending upon the volume of local anesthetic injected, it usually develops analgesia in the flank region from T8 to T12, and sometimes it also involves L1. In 2012, it was thought that why not we block the spinal nerves more closer to the neuraxial axis. So they arrived in this plane, that is anterior to the quadratus lumborum muscle. This, when we deposit local anesthetic here, it is known as the QL block or the quadratus lumborum block. The concept behind is that here the potential space was even lesser what was between the TAP plane. So if we deposit the same amount of local anesthetic here, it will have longer duration of action, and there was hope that this local anesthetic will trickle down and will also block the posterior primary ramus. However, studies have shown that quadratus lumborum muscle blocks the whole flank region. There is sparing of the posterior region. However, the spread is greater. Like I said, there is less amount of potential space, and hence the spread is greater. It is said to give analgesia from T6 to L2. Now, in 2016, it was thought that we should come even more closer to the neuraxial axis. Hence, this is the erector spinae muscle. This is the transverse process. If we inject local anesthetic just anterior in a plane between the transverse process and the erector spinae muscle, we will see that both the anterior and the primary rami get blocked, and some amount of local anesthetic, according to studies shown by according to spread shown by cadaveric studies, also reaches the paravertebral space and also the epidural space. So basically, if erector spinae block is like a service lane for neuraxial highway, where we don't have to pick the toll, but we might achieve the same speed and avoid traffic. Now, erector spinae block achieves the block of complete half of the abdominal wall from anterior to posterior, since it blocks both the anterior and the posterior rami. Now, I will illustrate how do we perform these blocks in our day-to-day practice. This is how we prepare for it. we can see the ultrasound probe cover. We can see our echogenic needle, which is easily seen in ultrasound. The cut sheet, our local anesthetic, our saline for hydrodissection. This is a small video in which we will illustrate transverses on this plate. The patient here is in lateral position, or also known as surgical position, is known as kidney position or flank position. This is the head end of the patient. This is the foot end of the patient. After painting and draping, we feel for the landmarks. For the ease of understanding, we have marked these landmarks. This is the iliac crest, and we have also marked the subcostal margin. The area between this is known as triangle of Pettit. We start scanning from the anterior axillary line from somewhere here. We come to the midline, that is mid axillary line. We usually get good view of all these three muscles. I'll pause our video in between. Right. So our ultrasound probe is somewhere here, and we'll get a view like this. As the schematic diagram suggests, this is the transversus abdominis muscle. This is the internal oblique muscle. This is the external oblique muscle. This is the subcutaneous tissue, and this is the skin. So, and this shiny structure underneath is the peritoneum. That is this thing, somewhere here. So basically what we do, we start from the inside. We identify the peritoneum. It is easily identified because of the movement it gets while with respiration. Then we identify the transversus abdominis muscle, and then we can locate internal oblique muscle. This plane, that is the plane between internal oblique and transversus abdominis muscle, is our plane of interest. Again, I'll play the video. We can see the peritoneum moving. This is our plane. Once we get a good view, we insert a needle with an in-plane approach, that is longitudinally. Again, going back to the sono anatomy. This is our needle. We have reached the transversus abdominis muscle, withdrew our needle slightly, reached the plane. We'll give a small test injection of saline. We can see the spread. We are happy with the spread. Now we'll inject 30 ml of 0.2% ropivacaine. See, we can see the plane splitting and the muscles separating. Over a period of time, this local anesthetic will spread over this whole region and blocks the lateral cutaneous nerves. And it also spreads vertically. Hence, we get that longitudinal spread also. Now we will move on to the next block. That is the quadratus lumborum block. The patient is in same position, that is the kidney or flank position. Here we start scanning from the midline. We identify these three muscles, but we keep on scanning posteriorly till we can find these three muscles tapering. Like this is the transversus abdominis muscle, this is the internal oblique, this is external oblique. TA has tapered. Internal oblique and external oblique are getting tapered. Can you see this muscle belly? This muscle belly is the quadratus lumborum muscle. We need to see the anterior facet of the quadratus lumborum muscle. Hence, we have increased the depth here. Now, this is the anterior facet of the quadratus lumborum muscle. So once we are happy with our view, we insert the echogenic needle with in-plane approach. So we can see the needle is coming from here. It is reached here. We have reached the anterior facet of the quadratus lumborum muscle. We'll give a small test injection of saline for hydrodissection and to see whether we are at the right plane. You can see small amount of splitting here. Then we will inject the 30 ml of 0.2% ropivacaine. Sorry, my cursor seems to get lost everything. Yeah, we can see the spread. As in the local, yeah, we can see the spread. This shiny thing sometimes occurs due to tiny air bubbles. Very minute air bubbles, they shine very bright in our ultrasound images. And this is the spread. Now we will move on to the third block. That is the Erector spiny plane block. In erector spiny plane block, our position remains the same, that is, patient is in lateral position. However, there is a slight difference, that is, we try to accentuate the spinal area. Hence, we flex the limbs and the head. I'll pause the video here. We have draped the area. We usually give erector spiny block at the level of T10 vertebra. We have marked those spinous processes, and then we will start scanning. We start from the spinous processes, then we go slightly lateral till we get a view like this. Once we start from here, we reach here, till we see the transverse process. I'll pause the video here for a second. Sorry. Yeah. So we can see this shiny knuckles. These are the transverse processes. And we can see this band. This is the erector spiny muscle. So according to the people who developed this block, Dr. Ferrero, he gave a model of, if we scan longitudinally along the vertebral column, we will see these transverse processes as picket fences. And this erector spiny muscles, which runs longitudinally above this transverse processes, looks like a clothesline. So they gave a name, picket fences, clothesline over the picket fences. Their idea was that if we inject local anesthetic here, it will spread not only to the, it will spread in longitudinally, it will also reach the paravertebral space, and it might also reach the epidural space. Now we will insert the needle again in plane approach. With in plane approach, we get greater safety as we tend to see the whole course of the needle. The needle is coming from here. Once we reach the transverse process, we give a small test injection of saline. What is shiny and moving below is the pleura. We give a small test injection, we can see the spread, then we give 30 ml of 0.2% opioid, we can see a nice spread. This is the transverse process again. This is the erector spiny muscle, which is now lifted up, and this is the pool of 30 ml, 0.2% opioid, which will spread longitudinally. So we have, I've introduced these Truncal blocks enough. Now we'll get to the hard numbers. In the year 2019, first month of 2020, that is January, we got 106 donor nephrectomies done. Out of this, 96 donor nephrectomies were done laparoscopically and 10 were done with an open approach. For 42 patients received erector spiny plane block, 33 patients received quadratus lumborum muscle block, and 21 patients received transversus abdominis plane block. All patients who received Truncal blocks received it with 30 ml of ropivacaine 0.2%. All patients received paracetamol 1 gram IV QID in postoperative period. In postoperative period, fentanyl IV PCA pump was instituted for all these patients. The bolus doses were set at 20 mics and maximum 3 to 5 doses were allowed in an hour. The fentanyl consumption was recorded from the PCA pump at 24-hour interval and between 24 to 48 hours interval. We recorded both static and dynamic pain. Now, static pain is the pain felt by the patient when he is lying at rest. Dynamic pain is the pain felt by patient when he is making a movement. For our recording, for our purpose, we recorded dynamic pain while we asked the patient to flex his legs. For recording pain, we use the VAS scale, which is a well-validated pain score. And we used a VAS scale from 0 to 100, where 0 was no pain and 100 was maximum pain. So static, dynamic pain and postoperative nausea vomiting was noted at intervals of 30 minutes, 2 hours, 6 hours, 12 hours, 24 hours, and 48 hours postoperative. We give rescue analgesia whenever there is breakthrough pain. Well, whenever despite our measures, patient complains pain. So we gave rescue analgesia on demand of the patient. For that, injection tramadol 100 mg slow IV infusion was given. One more thing. All these patients were in the pre-op period itself were explained about how to use the PCA pump, how to give boluses. Their relatives were also explained about the same. This is the graph depicting fentanyl consumption in the first 24 hours. Like you can see, the ES consume least fentanyl and TAP TAP consumed the maximum fentanyl. We'll see the tables later showing the numbers. The same pattern was also seen in fentanyl consumption between 24 to 48 hours. However, the gap between QL and the TAP here, that is at 48 hours period, the gap between QL and TAP block was lesser, while ES continued to be give least fentanyl consumption. This is the table showing the mean fentanyl consumption both at 24 hours and between 24 to 48 hours. We found that fentanyl consumption for 24-hour period was significantly less for the ES group. However, there was no significant difference in fentanyl consumption at 48 hours. We recorded the pain scores also. The pain scores, as we can see from our graph here across all time points, apart from 30-minute time interval, the pain scores were static pain scores were highest for the TAP group. That is transverse abdominal sprain group. While they continue to be least at all time points for erector spinae group. The QL group gave maximum reported maximum static pain at 30 minutes, but apart from that, the static pain scores of QL group were lesser than the TAP. When we talk of statistical significance, we found that erector spinae group was statistically reported significantly reduced pain numbers. I'm sorry, my cursor seems to get lost. The erector spinae group reported significantly reduced static pain scores at 30 minutes, 2 hours, and 24 hours. The dynamic pain scores, also the same pattern emerged. Apart from the 30-minute time period, the TAP group reported maximum dynamic pain scores. The ES group at all time points reported, apart from 6 hours, reported most least dynamic pain scores. When we talk about the statistical significance, we found that ES group reported significantly reduced dynamic pain scores at 30 minutes, at 2 hours, 6 hours, and at 48 hours. The QL group significantly reduced dynamic pain scores at 2 hours and 6 hours. We also recorded the number of patients who needed rescue analgesia. We found that in ES group there was significant reduction in number of patients requiring rescue analgesia. There was no difference in post-operative nausea vomiting when compared across all three groups. Now, we didn't encounter any complications. That is, there was no incidence of local anesthetic toxicity, viscera puncture, or lower limb weakness. Lower limb weakness might occur due to trickle of the local anesthetic, which is deposited in between muscle planes when it reaches the lumbar plexus. When it reaches the lumbar plexus, hence it results in lower limb motor weakness. However, we encountered technical difficulty in performance of two QL blocks. In this, we were able to visualize the QL blocks. However, we were not very happy regarding the anterior facet of the QL block, and we were not able to locate it well with our needle and saline hydrodissection. Hence, we decided to convert these two QL blocks into TAP blocks, and these TAP blocks were included in our study. Now, however, how does our results stack up against the contemporary review of literature? There are not many studies involving these blocks and this kind of surgery. There are not many RCTs. However, there are few RCTs where they have compared these blocks with surgeries similar to our laparoscopic donor nephrectomy. So, according to a study by Eniskevich et al., which was published in Journal of Local and Regional Anesthesia 2014, which was a prospective study, they compared TAP block with 20 ml of 0.25% bupivacaine versus sham block with 20 ml of 0.9% 7 in patients undergoing hand-assisted laparoscopic nephrectomy. They performed TAP for 11 patients and sham block for 10 patients. They reported significant reduction in morphine consumption. They also reported significant reduction in pain scores at only 24 hours. There was no difference in PONV or sedition scores. According to another retrospective study published in Clinical Research Trials in February 2020, They compared TAP block versus local skin infiltration in patients undergoing laparoscopic partial nephrectomy. They found there is significant reduction in pain and analgesic requirements in TAP group, and there is no requirement of opioid rescue. According to a prospective study which was published in BMC Anesthesiology 2019, they compared both QL versus epidural, which we regard as a very good, effective way of giving postoperative analgesia. They studied they included patients undergoing lap nephrectomy, 31 in the each arm. They found there was comparable opioid consumption till 48 hours, and there was no difference in postoperative nausea, vomiting, and Gromit score. Now, Gromit score is a scale which is used to measure the amount of motor weakness or block after we give neuraxial anesthesia. For erector spinae, since it is a relatively newer block, we did not find any randomized controlled trials. However, we did find few case series done in patients undergoing same surgery, that is laparoscopic nephrectomy. According to a case series published by Tapas et al. In Indian Journal of Anesthesia, July 2018, they gave erector spinae block with 20 ml of 0.2% ropivacaine and inserted a catheter in the same plane. The catheter, the plane which we saw in our ultrasound sonar anatomy, they inserted a catheter in it through the needle, and they gave 0.1% ropivacaine at 8 ml per hour for 48 hours. They studied 4 patients. They gave this erector spinae block in 4 patients with catheter, and they kept the catheter for 48 hours. There was no need for rescue opioid for 48 hours. Another case series published in Saudi Journal of Anesthesia, they gave erector spinae block, single shot erector spinae block in patients of laparoscopic nephrectomy, and no rescue opioid was needed in postoperative period. Compared to all this literature, our retrospective data shows that in ES group there is reduced opioid requirements up to 24 hours in erector spinae group, and there is reduced dynamic pain up to 48 hours in erector spinae group. So what will be our future endeavors? In future we plan to combine the use of catheters and the truncal blocks. The advantage with catheters is that we can give a continuous infusion, we can give top-up doses of local anesthetic if there is a breakthrough pain, and we can prolong the duration of the action of these truncal blocks. We also plan to use liposomal local anesthetic as and when they are introduced in our country. While liposomal local anesthetic, what happens? There is an aqueous core containing the local anesthetic, which is surrounded by a phospholipid layer, which is hydrophobic. Now, small amount of local anesthetic, which is in a neutral form, seeps out into the surrounding tissues slowly. So it prolongs the duration of action of the local anesthetic. Studies involving liposomal bupivacaine have been done in Western countries. It is freely available there, and they have reported similar safety profile and prolonged effect up to 96 hours. So liposomal local anesthetics, when compared with truncal blocks, will lead to wider usage of truncal blocks. In conclusion, we would like to surmise that truncal blocks are effective way to provide excellent postoperative pain relief. In our experience, erector spinae block on preliminary data analysis appears to be superior. We felt that QL block was most technically difficult, followed by erector spinae block, and followed by TAP. TAP was simplest to perform. Thank you.